Well, thank you to the organizers for inviting me to this excellent event. It's a privilege for me to be here and to do this talk. I was asked to do a talk on how to manage comorbidities, in particular focus on kidney function. I'm a nephrologist at Lakeridge Health, formerly from St. Mike's, and I do a lot of clinical research in the field of chronic kidney disease, which overlaps with cardiovascular disease. Obviously, again, I'm privileged to give this talk. Thank you. These are my disclosures. Again, I do a lot of consulting for various industry partners with respect to usually chronic kidney disease, diabetes, and some vascular things such as anticoagulation. I've been involved with some of these companies in an advisory capacity, doing accredited speaking engagements. And I've got a lot of clinical trials where I'm a local or even national principal investigator for in the field of diabetes, chronic kidney disease, anemia, as you can see listed below. The objectives of today's talk are to help you understand the association and overlap between patients living with both heart failure and chronic disease and these populations, and the fact that there is a large overlap. To appreciate that chronic kidney disease patients are at increased risk of not only atherosclerotic cardiovascular disease, but also heart failure and hospitalization for heart failure. To recognize that amongst the patients living with heart failure, if there's kidney disease, either in proteinuria or reduced kidney function, or perhaps both, that's associated with worse clinical outcomes. And that really the best way to manage these patients isn't just by one simple algorithm, but by a sort of shared care approach of multidisciplinary, multi-professional groups working together with the patient and their family to try and sort of nuancedly treat their condition. So this overlap in the first introductory section, kidney dysfunction is common in people with underlying heart failure. Patients with heart failure have many comorbidities, and chronic kidney disease is but one, and really related to the fact that they have very similar underlying risk factors and mechanisms of disease. It turns out that somewhere between about 35 and about 45% of patients who have heart failure will have some form of CKD with reduced GFR, less than 60, or maybe about a third to 40% of them will have albuminuria or proteinuria, usually microalbuminuria, but sometimes even more overt proteinuria, particularly if they have underlying diabetes or other illnesses. So really, taken all together, there's a lot of overlap between heart failure patients and chronic kidney disease patients. The lower your GFR or the worse your proteinuria, the worse your risk for mortality related to heart failure or hospitalization for heart failure in these patients. And, depending on the underlying baseline characteristics of these patients, diabetes, hypertension, their baseline kidney function, medications that they're on, will also portend worse renal outcomes for these patients who have heart failure. In this meta-analysis of about 20,750 patients who have both HFrEF or HFpAF, you can see that either if you use the MD-RD equation to assess GFR, or the more commonly used equation now, which is the CKD-EPI equation, that there are a lot of patients in this bar graph who have GFRs in the less than 60 category. And in this particular meta-analysis cohort, about 55% of patients who had heart failure had underlying chronic kidney disease. From the CRIC, the chronic renal insufficiency cohort, which is a 5-year follow-up, looking at hospitalization for heart failure in patients with CKD, in almost 4,000 patients, there were about 1,774 hospitalizations. Some patients had no hospitalizations, but some had as many as 17. And again, the overall average hospitalization rate was about 5.8 per 100 patient years, and again, about 36 per 100 patient years of days in hospital. So it's a large burden of illness of these patients. And if you look at the bar graph on the right, you can see that on the leftward side, GFR, the lower your GFR, the more your risk for hospitalization for heart failure. If we look in the middle section, the albuminuria, either a no proteinuria or an ACR in the American units of less than 30, that would be about 3 in our units. The middle bar would be microalbuminuria patients, and an overt nephropathy greater than about 33 milligrams per millimole. Again, as your proteinuria goes up, your risk of hospitalization for heart failure goes up. And then when you put these things together, either proteinuria or CKD, you can see there's a graded risk in these patients. Again, if you look at the same CRIC cohort, And the top part of this chart are the odds ratios, or the hazard ratios rather of progression of kidney disease by decline in 50% or ending up on dialysis. The bottom section is all-cause mortality. And what we see in the rows are the number of hospitalizations for heart failure over a 0 to 2 year period, if it's 0, 1, or greater than 2. And you can see that the unadjusted odds ratio, or hazard ratio rather, is 3.21. But even when you adjust it for known risk factors and other comorbidities, we've got at least a doubling of progression of kidney disease, or progression to end-stage renal disease in these patients with multiple admissions. And then all-cause mortality is increased even further, up to about a 5 times increase, and again, adjusting maybe down to 3 times, but still very, very high risk for both cardiorenal and mortality outcomes in these patients. When we look at the mechanisms, again, when I went to medical school, or very simply, when you think about it, heart failure patients had reduced cardiac output and cardiac index. That led to renal hypoperfusion, a low flow state, renal vasoconstriction and hypoxia, and perhaps ATN in the worst case scenario, resulting in kidney failure. What we know now is it's a heck of a lot more complicated than that, and there are a lot of hemodynamic mechanisms, neurohormonal mechanisms, and then disease-specific related mechanisms related to the underlying chronic kidney disease and the cardiovascular disease association between the two groups of patients. So if we drill down these a little bit more, the hemodynamic mechanisms related to the decreasing cardiac output, the arterial pressures being elevated, the cardiac congestion, the increased fluid overload, salt and water retention, activation of the renin-angiotensin system, as well as aldosterone excess. And then, of course, things we've learned recently is the ANP and BNP and arginine vasopressin, et cetera, plus a lot of inflammation, fibrosis, and other aspects of care here. So this is a very complicated thing. Again, not the focus necessarily of today's talk, but just to let you know there's a lot going on, not just renal congestion, not just low GFR because of low cardiac output, but a lot of hemodynamic mechanisms. When we look at the neurohormonal side, again, with heart failure, a lot of individual cytokines and hormones that are elevated, arginine vasopressin, salt and water restriction due to aldosterone and increased ANP, BNP, renin-angiotensin system activation, sympathetic activation. And again, these are then become targets of individual therapeutic approaches along the way. So understanding the mechanisms helps with respect to bench to bedside, therapy for these patients. And then there's kidney-specific mechanisms of, the patients that I deal with declining kidney function have bone and mineral metabolism problems, abnormalities of calcium and phosphate, hyperparathyroidism, anemia, chronic inflammation, malnutrition, and a lot of other factors, as you can see there. And again, we don't need to go over all of them, just to let you know that there's a lot going on. And in our multi-care kidney clinics, we try and treat these to try and help overall outcomes, not just kidney outcomes, but vascular outcomes as well. When we think about the cardiorenal syndromes, to try and help us understand these a bit better, rather than just dealing with one name, we try and categorize them into 5 different categories, trying to differentiate the underlying pathophysiology is really what we're trying to do here, as well as to sort of get a bit of a handle on what the organ dysfunction and what the sort of leader in this story was. So for example, if someone has an acute heart failure event, this can lead to acute kidney injury. So this would be type 1 cardiorenal syndrome. So the heart was the driver here, the kidney is the follower because of the altered hemodynamics and other factors. You can also have someone with chronic heart failure. And again, this is our more traditional cardiorenal syndrome patient. And those patients then chronically may have progressively declining kidney function, altered, fibrosis and apoptosis, and, a whole bunch of other hemodynamic chronic mechanisms that will be dealt with by both the cardiologist and the nephrologist. You can, of course, have acute kidney injury that leads to heart failure. Someone with sudden onset of kidney failure whose urine output goes down, they can't excrete enough salt and water. There's a whole bunch of other imbalances. These patients can go into acute volume overload and even heart failure, frankly. Or chronic kidney patients can also suffer the same issues, leading to more trouble and more difficult issues for the sort of failing heart to deal with. And of course, the 5th category really are overwhelming illnesses like sepsis, where there's microcirculatory dysfunction or other severe catastrophic issues that are affecting both organ systems at the same time. When we think about therapeutics, there are a few clinical pearls with respect to heart failure management in people with chronic kidney disease. First and foremost, like anything, prevention is the key. Volume control is a very important part of this. And again, that doesn't just mean diuretics. It means understanding what this patient's individualized target volume approach is. Explaining to your patient about sodium restriction, explaining to your patient on how to weigh themselves and what to set as and how to assess a target weight, and how to determine whether that's an appropriate target weight. And we would review that at each clinic visit and help them to self-manage their own diuretics, help them to optimize their cardiorenal medications, and most importantly, that shared communication in an ongoing way with the patient, their family, and their support givers, the primary care team, the cardiology and the nephrology clinics, the heart function clinic if they're plugged in. And this bidirectional communication is exceedingly important. If we look now at the prevention story, clearly an ounce of prevention is worth a pound of cure. And there's a large overlap between the cardiovascular patient, the diabetes patient, the chronic kidney disease patient, and the heart failure patient. And again, much of this is really for all of these patients. Similar pathophysiology, healthy weight, exercise, smoking cessation, maintain a good blood pressure, control the diabetes, control the cholesterol with statins or other therapies where appropriate, optimize cardiorenal medications, avoid medications that could be making things worse, like nephrotoxins, and we can talk about that in a bit, and then ongoing regular care and follow-up in the primary care setting, again with good communication in both directions to the other teams that are involved. From a salt point of view, this is something that we often forget to tell our patients. We say, hey, are you using too much salt? And they're saying, no, I don't add salt. That's only maybe about 10% of the salt in our food. 90% of the salt in our food is either innate or is it from processing, and the most of it is from processing, canned foods, boxed foods, eating out at restaurants, etc. 90 millimoles a day is our target. That's about 2 grams of sodium a day. Most Canadians eat more than that. About 95% of Canadians eat above that level on a daily basis. So the KDIGO, the Kidney Global Guidelines of both chronic kidney disease, or in this case, diabetic kidney disease, have nutrition salt restriction right at the base for all patients, along with the other risk factors, and then the particular drugs above, like SGLT2 inhibitors, RAS inhibitors, antiplatelet drugs, etc. Again, there's good quality evidence for controlling blood pressure with salt restriction, moderate quality evidence for cardiovascular and stroke outcomes, and there's some evidence for progression of kidney disease. If you now look at the more traditional therapeutics, the drugs that we use in these patients, the red pyramid in the middle, again for patients with heart failure and those with kidney disease, but in patients with heart failure and kidney disease together, often a RAS inhibitor-based therapy, either an ACE inhibitor or an ARB if not tolerated, more commonly now and often for these more advanced HFrEF type patients, an ARDI is the right therapy. And then we go up the cascade to beta blockade, MRA or mineralocorticoid receptor agonists, and then in select patients, ivabradine, and perhaps in some patients where they're intolerant to the other drugs, intolerant to RAS, etc. Maybe they use other vasodilators or even digoxin, etc. Rate control. What hasn't made it into this chart, of course, is the newest kid on the block, and that's the SGLT2 inhibitor, which really has had some unbelievable success in clinical trials over the last little while. I'm going to focus a little bit more on that in the next couple of slides. Along the way, while we're treating this patient in front of us with these therapies where appropriate, and try to optimize based on guidelines from randomized trials, of course, that we've got to remember that we've got to connect with the kidney clinic, and we've got to, whether this is a multi-care kidney clinic patient pre-dialysis or somebody who's either got acute kidney failure that might need support in the ICU with CRT or the kidney team involved, or perhaps they progress to chronic renal failure and stage renal disease and need dialysis or transplantation. Hopefully those are on the low side, and that most of these people we can keep in the pre-dialysis setting. And again, good communication with all members of the teams is important here. Other considerations, of course, again, back to avoiding nephrotoxic agents. It's amazing how many people that I see have never been told that they shouldn't take an NSAID. I thought everybody knew this, as well as drug dosing and avoiding aminoglycosides and avoiding contrast. If possible, it's amazing how many times people get a CT contrast when really an ultrasound or an MRI would have been just as good. So this is important things to think about in your patient with advanced kidney disease, especially when they have heart failure. treating underlying illnesses like the bone and mineral metabolism and vitamin deficiencies, etc. And then, of course, other things. And again, this is certainly not the talk today about ICDs or cardiac resynchronization, but again, many patients have done unbelievably well, and it's amazing to see kidney function improve with such therapies. So another thing that's important is a patient who gets admitted to the hospital. I'm often consulted to see these people because they've got a slight acute on chronic kidney disease during their heart failure hospitalization, and somebody along the way has stopped their ACE inhibitor or their ARNI or their other medications, and that's often done transiently, but sometimes it's done even at the point of discharge, and then these patients come back into the hospital later. It's important to recognize that improved mortality, decreased readmissions, and decreased length of stay have been documented when we continue these therapies. There's at least 20 studies or randomized trials that have shown that, and that we've shown reduced hospitalizations. Clearly, if somebody has acute renal failure to the point of severe acute kidney injury, severe hypotension, severe hyperkalemia, these drugs might need to be stopped temporarily and then restarted while in hospital, perhaps at a lower dose and then adjusted. But it's important to remember to get these patients back on optimal therapy as quickly as we can. I want to focus a little bit specifically on SGLT2 inhibitors because they've certainly rocked everybody's world, not just the endocrinologists, but the cardiac world, the heart failure world in particular, and the chronic kidney disease, diabetic nephropathy, and now non-diabetic nephropathy patients. SGLT2 inhibitors have a lot of cardiorenal mechanisms. Clearly, these drugs block the sodium glucose linked transporter in the proximal nephron and the proximal convoluted tubule, and therefore lead to increased glycosuria as well as increased natriuresis or sodium excretion, and that's of course the basic mechanisms. That leads to a reduction in intravascular volume briefly. It leads to a reduction in weight because you're losing glucose. It leads to a reduction in your blood sugar. These drugs, after all, were initially glucose-lowering drugs, but there's a lot of other aspects here that we've seen. These drugs have reduced LV wall stress. They have increased oxygen delivery. There's a beta blocker-like effect because of sodium hydrogen exchange inhibition, so therefore there's less oxygen demand or decreased oxidative stress. There's a lot of other alternate fuels that are available, and as well as a whole bunch of other things as mentioned here. So which one thing is important, or is it just the fact that all of these things are happening? Again, I'll leave it to the individual person to decide. Our love with these agents started back in 2015 with the first ever diabetes trial to show that during the course of a trial, we had positive reductions, clinically positive, clinically significant, and statistically significant reductions in the primary cardiovascular outcomes. In this particular case, MACE, the 3-point MACE. This was the EMPA-REG outcome trial, and as you can see, not just a big reduction in MACE, very clinically important, but also a reduction in these people with diabetes of cardiovascular death, of hospitalization for heart failure, as well as the composite renal outcome of progression of kidney disease, declining kidney function. So this led, a lot of people to think, man, if these drugs work that well in people with really not a lot of established end organ damage, what about we do dedicated heart failure trials? What about if we do dedicated kidney trials? Are we going to see the same magnitude of benefit? So let's look, first of all, at sort of a bit of a meta-analysis of the SGLT2 inhibitor CV outcome as well as renal trials, looking at the renal outcomes. So again, when you're looking at secondary outcomes of renal outcomes, then you're not quite as impressed that these are, kidney or nephroprotective drugs. But when you put all of them together, including in this analysis, the Credence study, and this analysis doesn't unfortunately include DAPA-CKD, but we can see about a 40% reduction in progression of renal outcomes, very important renal outcomes, particularly in Credence, which I'll talk about in a second. What is evident in this meta-analysis is the top half of this is in people with underlying symptomatic or history of atherosclerotic cardiovascular disease. The bottom half are the so-called primary prevention patients. The kidney doesn't care if you've had a heart attack or not. If a drug works to protect the kidney, it works to protect the kidney irrespective of the previous cardiovascular disease. So this is very important. This is not seen, for example, with the GLP-1 receptor agonists or some of the other drugs that we've seen for diabetes. It's really just in this setting. Again, if we look at heart failure outcomes in these patients, hospitalization for heart failure in these same trials, in patients both with established cardiovascular disease and without cardiovascular disease, about a 30 to 37% reduction in the heart failure outcomes in these patients. Again, MACE was reduced only in those with established cardiovascular disease, not in those with risk factors, but both chronic kidney disease outcomes and heart failure outcomes are reduced even in the primary prevention patients. From dedicated renal trials, we see that there's a large reduction in these credence and DAPA-CKD in the primary renal outcomes, the hard renal outcomes, as well as cardiovascular outcomes, a reduction in hospitalization for heart failure, CV death, and all-cause mortality. And again, if we look here at credence and at DAPA-CKD, a very large reduction in hospitalization for heart failure and CV death. If we now look at the dedicated heart failure trials, we can see that around 40% of the patients in the DAPA heart failure study had CKD, and that as your GFR declined in that study, the blue curve is the relative risk reduction or the reduction in the primary outcome. It's preserved as your GFR declines, and again, that shows that these cardiorenal patients also have benefits from the SGLT2 inhibitors. And again, if you're looking at in that DAPA heart failure study, a positive reduction in composite renal outcomes, in the doubling of your creatinine is reduced quite significantly. Similarly, in Emperor reduced, very important renal outcome benefit in these heart failure treated patients with an SGLT2 inhibitor. And so in summary, cardiovascular protection in SGLT2 inhibitors is really robust and is seen in the cardiovascular trials, in the renal trials, and the heart failure trials, and we see reductions in all of these different outcomes. So again, the KDIGO practice guidelines really have put SGLT2 inhibitors as part of the renal cardioprotective drugs in the pyramid. And in conclusion, my overall conclusion, again, these are complex patients, cardiovascular patients, chronic kidney disease patients, heart failure patients, all share overlapping Venn diagrams. There's a large population of overlap of those with both heart failure and chronic kidney disease. In patients with heart failure, the kidney is an important marker of risk and outcomes. Optimizing medical care in a nuanced approach with all of the different teams being involved, including the family, of course, as the most important team, and the fact that there's a lot of new therapies out there, and that most of these new therapies are very exciting because they don't just improve one or the other, they improve both the cardio-renal outcomes. Thank you very much.